Welcome to Section 8 in Neurology. In this section, we will be focusing on ophthalmology, including the visual pathway and its vascular supply, the pupillary light reflex, and the autonomic innervation of the eye, as well as internuclear ophthalmoplegia, or INO. So let's get started. So now let's discuss the visual pathway. So starting with the temporal hemiretina, which is the lateral halves of each retina in each eye. It goes from the temporal hemiretina, the optic nerve, and then it goes through the optic chiasm, and anything temporal stays ipsilateral. It does not decussate. And then after it goes through the chiasm, it goes to the optic tract. Again, staying ipsilateral, it finally goes to the lateral geniculate body. And then from there, the fibers go through the optic radiations, including the dorsal optic radiations, as well as the Meyer's loop, which is also called the lateral optic radiations, and then goes to the primary visual cortex in the occipital lobe. Now the nasal hemiretina is the medial half of each retina in each eye. From there it goes to the optic nerve, and then from the optic nerve you would go to the optic chiasm and then the contralateral optic tract. So it has decussated at the optic chiasm. And then it'll go to the lateral geniculate body, again on the contralateral side, and then it'll go to the optic radiations, and then finally the primary visual cortex. So let's draw this out. So here is figure 8.39 from your text showing the visual pathway. So as you can see, we're looking at the left side, and if you look at the left temporal hemiretina, so this half of the retina, then we'll follow that through the optic nerve, and then it'll go to the optic chiasm, and then it'll stay ipsilateral until it gets to the lateral geniculate body, and then it'll go through the optic radiations. We'll have the Meyer's loop, as we've labeled on this side, and the dorsal optic radiation right here, until it finally reaches the primary visual cortex. Now if we're looking on the right side, we'll just focus on the nasal hemiretina, so this medial half of the retina. It will go through the optic nerve, and then it will decussate at the optic chiasm until it reaches the lateral geniculate body. And of course, it will also go through the dorsal optic radiations and Meyer's loop, or the lateral optic radiations, until it finally reaches the occipital cortex on the contralateral side. Now the same is true for the right temporal hemiretina. That'll stay ipsilateral. And then the left nasal hemiretina. And then we'll go through the Meyer's loop and dorsal optic radiations and then go to the primary visual cortex. So now let's talk more about the optic radiations. First, the dorsal optic radiations, these traverse the parietal lobe and then synapse on the occipital cortex. Now this carries information from the top half of the retina, which actually ends up being the lower field of vision. And then we have the Meyer's loop, which we can also call the lateral optic radiations, which traverse the temporal lobe, and then finally synapse on the occipital cortex. And this carries information from the bottom half of the retina, which is the upper field of vision. We'll elaborate more on that. So to summarize, if we are looking at the back half of the retina, you can see that the top half, we'll just fill it in here, is responsible for the lower field of vision, because the lower field of vision will reach the top half of the retina. And then the bottom half of the retina, we'll just fill it in this color, is responsible for the upper field of vision. So now if we're just going to focus on the left side for a moment, you can see that the temporal hemiretina is actually responsible for the medial half of the field of vision, as you can see with this arrow. Same thing is true for the medial half of the retina, or the nasal hemiretina. That's responsible for the lateral field of vision. In other words, from the perspective of any point on the retina, the field of vision is upside down and backwards. So this will make more sense after we do some examples. Now before we jump into some examples, let's talk about how to rock the visual field questions you're going to get on step 1. So one of the first things you need to determine, depending on the question, is know the location of the lesion within the visual pathway. And then you need to know what part of the retina will be dysfunctional. So you identify the retina, and then you flip it upside down and backwards, and that will give you the field of vision deficit. So visual field questions will come in a variety of forms. So you may be given the field of vision first, then you think, okay, I need to work backwards and determine I need to flip that upside down and backwards, and that'll give me what part of the retina is damaged, and then from there you determine the location of the lesion. So you just need to be able to do all three of these steps in any order. So let's do an example. So let's get more specific about the lesions. So if you damage this left optic nerve right here, you will get left anopsia. And so if we had the field of vision, we'll just show both eyes. There will be a total deficit in the left eye. So we determine the lesion location, and then we determine the retina deficit, and then finally we determine the visual field deficit, which means they cannot see out of their left eye entirely. So now let's say we damage the optic chiasm, right here. If you damage the optic chiasm, you will lose the signal from the nasal portion of the retina on both sides, so this medial portion, because they try to decussate and they cannot get across. So what would the visual field look like? So they would get bitemporal hemianopsia. So bitemporal meaning they can't see the lateral halves through either eye. So they lost their peripheral vision. So again, this is called bitemporal hemianopsia. So now let's say we damage the dorsal optic radiations on the left side. So that would be these right here. So the next thing we would determine is the retinal dysfunction. Now the dorsal optic radiations are responsible for the upper retina. So the left optic tract right here carried information to the lateral geniculate nucleus from the left side of each retina, which means this right nasal hemiretina, which decussated, and then this left temporal hemiretina, which did not decussate. So we've identified what portion of the retina is damaged. So to summarize, we know we have damaged the dorsal optic radiation on the left side, which means we lost the left, as we've determined, the left on each side, and upper. So it's the left upper quadrant of each side of the retina is damaged. So what would be the visual field loss? Well, we just take that, make it upside down and backwards, which would be the right lower quadrant, which means this patient has right lower quadrantic anopsia. So now let's say that the Meyer's loop on the right side is damaged. So we damaged it. So recall that the Meyer's loop carries the signal from the bottom portion of the retina, specifically on the right side of each retina. So the Meyer's loop is responsible for the bottom half, and since we're on the right side, we're only dealing with the right temporal hemiretina and the left nasal hemiretina. So we're only dealing with the right lower portion of each retina. So what would be the visual field loss? Well, it would be upside down and backwards. So we would have lost the left upper quadrant, which means it would be left upper quadrantic anopsia. So now let's say we damage the optic tract on the right side, so right here. The optic tract on the right side is responsible for the right half of the retina in both sides. So right there, right here. Because the left nasal hemiretina will decussate, and then the right temporal hemiretina will stay ipsilateral. So we know that we lost the right portion of each retina, the right half of each retina in both eyes. So what would be the visual field loss? So if everything's upside down and backwards, the upside down part isn't really relevant here, but the backwards part is. So the patient would actually have a visual field loss on the left side. So it would be left homonymous hemianopsia. For the left homonymous hemianopsia, you can say that the visual field would just look something like this, because the visual field is only really singular in most cases. We just break it down with each eye. So this one, where we damaged the Meyer's loop on the right side, the visual field would just look like this. This is what the patient wouldn't be able to see. Same thing with this dorsal optic radiation lesion on the left side. It would simply look like this. And it's a little bit more complicated when we talk about bitemporal hemianopsia, because we just discussed that the patient has lost peripheral vision, and then left anopsia, where the patient simply can't see out of their left eye. So knowing the visual field and the results of any lesion along the pathway is extremely high yield. So we have also created figure 8.40 for your reference. So you can see all of the different lesions and the result of the lesion with this diagram. So now let's apply this knowledge with some questions. Let's say a patient is unable to visualize anything on her left. What part of the visual pathway is likely damaged? So the patient is describing a visual field that looks like this. So you can't see on the left side. So what part of the pathway would cause this visual field? So we first need to decide what part of the retina is responsible for the left half of the visual field. We follow the field to the retina, so we can see that the left visual field comes from the nasal hemiretina on the left side, decussates, the right temporal hemiretina on the right side, because that would make up the right half of the retina. So it's backwards from the visual field. And then of course it goes through the Meyer's loop and dorsal optic radiations until it reaches the right primary visual cortex. So where along this pathway in red, anywhere in red, where was damaged? Was it the primary visual cortex? Was it the Meyer's loop plus the dorsal optic radiations? And recall, we would have to damage both of them to cause a complete hemiretina, because recall that the Meyer's loop is only responsible for the lower half of the retina, and the dorsal optic radiations are responsible for the upper retina. So we'd have to damage both of them together. Or we could damage the lateral geniculate nucleus, and that would cause this. Or we could have damaged the right optic tract right there. So it's not very likely that it would be the lateral geniculate nucleus. Just to damage that is difficult, it's not very common. And to damage the Meyer's loop plus the dorsal optic radiation at the same time is not really likely, so we're not thinking it's the dorsal optic radiations. But it could be the primary visual cortex, or it could be the optic tract. So without more information, you can't really determine that. But we can safely say that we think it's one of these two. So now let's do another question. Let's say there's an elderly female patient, who has a tumor on the left temporal lobe. So it's on the left. What visual field defect might she have as a result of the tumor? So we're trying to find the visual field defect. So here we are given the tumor in the temporal lobe, so it's the left temporal lobe. Now, what part of the visual pathway uses the temporal lobe? Well, that would be the Meyer's loop right here, or the lateral optic radiations. So we are dealing with the left hemisphere of the brain. So if a temporal lobe tumor damaged the Meyer's loop, this patient would lose the function of the lower retina. And this would be on the left and right side. Just think this side, the temporal hemiretina uses that, and then the right nasal hemiretina will also use that. So what would be the visual field defect if she lost the lower quadrant of each retina? Well, we just take that upside down and backwards, and the visual field defect would be the right upper quadrant. So this would be right upper quadrantic anopsia. So the macula is a part of the retina. It's the, again, center field of vision, and it's the center of the retina, essentially. So macular degeneration would lead to central loss of vision. Now, the portion of the occipital cortex devoted to the macula is supplied by the middle cerebral artery. So if you have a posterior cerebral artery that damages the occipital cortex, then we will have macular sparing. It'll spare the macula. And we'll explain this situation in a little bit more detail when we get to the vascular portion of this lecture. So let's say there's a 64-year-old female patient who complains of a blurry spot in the middle of her vision. Where is their damage likely to be? So this patient is complaining of central loss of vision, which looks like that. So right there in the center, she cannot see. So this should instantly make you think of the macula. So central loss of vision should also make you think of the occipital cortex. So you could have damaged back here if there was a MCA infarct, or we should have damage to the center part of the retina. So this will make more sense after we talk about the blood supply to the visual pathway. So we have the retina, which is supplied by the ophthalmic artery. And the ophthalmic artery comes from the internal carotid. It's a branch of that. And the optic nerve and then the chiasm are innervated by branches of the anterior cerebral artery. And then the optic tract is supplied by the anterior choroidal arteries, which are part of the MCA, and then the posterior communicating arteries. The lateral geniculate nucleus is supplied by the anterior choroidal, which is a portion of the MCA, just like the optic tract. And then it's also supplied by the posterior choroidal arteries from the ACA. The optic radiations, so the dorsal optic radiations and the Meyer's loop, are supplied by both the MCA and the PCA, and the occipital cortex is supplied by the PCA, or posterior cerebral artery. So as you can see, there is quite a bit of crossover between what arteries supply each portion of the visual pathway. For example, if a patient gets a right PCA infarct, they will likely demonstrate left homonymous hemianopsia with sparing of the macula. However, with an MCA infarct, it's not perfectly clear what parts of the visual pathway could be affected, if at all. For example, the MCA supplies the lateral geniculate nucleus, but so does the ACA. Another example is the MCA supplies the optic radiations as well as the PCA. The point is that determining what portion of the visual pathway is damaged based on a certain type of stroke is not realistic. So don't spend too much time memorizing the blood supply of the visual pathway. Just know two things. The occipital cortex is supplied by the PCA. Next, know that the ophthalmic artery is supplied by the internal carotid, and that supplies the retina. Those are the two highest yield things you need to know about the blood supply to the visual pathway. So if you know those two things, you'll be in great shape for step 1. Now this is figure 8.41, which is just for your reference. Again, what you need to know is the occipital cortex, back here, is supplied by the posterior cerebral artery. So know this box. And know that the retina, this box, is supplied by the ophthalmic artery, which is a branch of the internal carotid. So know those two portions. So I'll ask you a question. Let's say there's a 73-year-old male patient who is found unconscious on his living room floor. After regaining consciousness, he complains of loss of vision on the left side with full vision in the center. Neurologic imaging indicates a stroke. Where was the stroke likely to be? So we got to identify where the stroke is. So let's look at the visual pathway again. So if his visual field is essentially looking like this should make you think of two things: damage to the optic tract on the right side or damage to the occipital cortex on the right side. And again, we're thinking right because the right hemiretina is responsible for the left field of vision, because again, we go upside down and backwards. And again, we're not thinking that he just damaged the Meyer's loop with the dorsal optic radiations, because if one of these two would be damaged, then we would just lose a quarter of vision, not a complete half of vision. And damaging them both at the same time is just not realistic. He also stated that he can see the center just fine. In other words, there's sparing of the macula. So in other words, this is macular sparing. So this implicates a PCA infarction, which means we're thinking that the right occipital lobe is what was damaged. So going back to our question, in a patient with left homonymous hemianopsia with sparing of the macula, the patient has likely to have had a PCA infarct, which is where we think the stroke is. Now let's talk about the parasympathetic innervation of the eye. Just remember that the parasympathetic innervation of the eye is mediated by cranial nerve 3, the oculomotor nerve. So innervation starts in the midbrain with the Edinger-Westphal nucleus, then the ciliary ganglion, and then the short ciliary nerve, which innervates the pupillary sphincter muscle. When activated, it constricts the pupil and causes meiosis. And then the other thing is accommodation, which follows the same path: the Edinger-Westphal nucleus in the midbrain, ciliary ganglion, short ciliary nerve to the ciliary muscle, which performs accommodation. It's accommodation of the lens. So here's figure 8.42, showing the parasympathetic innervation of the eye. As you can see here, we have the Edinger-Westphal nucleus, which sends fibers through the ocular motor nerve, right here. We have labeled the nucleus. And the ocular motor nerve sends a signal to the ciliary ganglion, labeled right here. And then the ciliary ganglion sends fibers to the pupillary sphincter muscle, this blue line, which is labeled right here on the left side, and it causes meiosis. We will talk more about the pupillary light reflex and the role of the pupillary sphincter muscle later in this lecture. For now, just focus on the parasympathetic innervation of the eye in general. The next thing to know is that the ciliary ganglion can also innervate the ciliary muscle surrounding the lens. So this green line on this left side and on the right side. And when the ciliary muscle is stimulated, it will cause accommodation of the lens. Now, accommodation just means you can change the shape of the lens to properly focus objects on the retina. We're not going to talk much more about accommodation, but it's important to know that it is accomplished through the parasympathetic innervation of the eye via the ocular motor nerve. So now let's talk about the pupillary light reflex. So the retina receives the light stimulus, and then the cranial nerve 2, or the optic nerve, will send information to the pretectal nucleus in the midbrain. From the midbrain, fibers travel to the ipsilateral and contralateral Enger-Westphal nucleus. From there, the cranial nerve 3, or the oculomotor cranial nerve, sends fibers to the ciliary ganglion bilaterally, so both sides. And then from there, the short ciliary nerve carries information to the pupillary sphincter muscle, and then the patient gets meiosis. And I want you to pay special attention to the fact that it's ipsilateral and contralateral and then bilateral. Point being is that light can come in from the right side, but both the right and left eye will cause pupillary constriction or meiosis. So let's draw this out. So here is figure 8.43 showing the pupillary light reflex. So light will reach the retina in the back of the eye. We'll just focus on this right side for now. And then it will travel to the pretectal nucleus, following the optic nerve down to this pretectal nucleus back here. So in this case, it'll hit the right side. Again, this is within the midbrain. Keep in mind that the nasal hemiretina on the right side sends fibers that decussate at the chiasm and synapse on the left pretectal nucleus in the midbrain. In other words, both pretectal nuclei will be stimulated from the afferent signal in the right eye. For this illustration, to keep things from getting too messy, let's just focus on this right pretectal nucleus, but recognize that both are stimulated. And then fibers will travel from this pretectal nucleus to the Enger-Westphal nucleus on both sides. So it's bilaterally at this point, as you can see in this image. From there, cranial nerve 3 carries parasympathetic innervation to the ciliary ganglion. And from the ciliary ganglion, the short ciliary nerves will carry the stimulus to the pupillary sphincter muscle. So the pupillary sphincter muscle will be activated and will lead to meiosis of both eyes. So as you can see, if you shine a light into the patient's right eye, then the Enger-Westphal nucleus on both sides will be stimulated. So both pupils will constrict. This pathway is super important and very clinically relevant, not to mention a goldmine for examiners writing test questions for step 1. So let's just work through a few questions to help you get prepared for how you might be tested. Okay, so a patient has severe retinal detachment of the left eye. How will the right eye respond when light is shown through the left eye? Okay, so looking at this image, the patient has retinal detachment of the left eye. So we are thinking there is damage to the afferent part of the pupillary light reflex through that eye. And afferent is simply referring to the optic nerve, because the optic nerve is what carries the signal to the midbrain. So if the optic nerve is not sending the signal to the pretectal nucleus on the left side, then there will be no stimulation of the Enger-Westphal nucleus on either side. So going back to our question, what will happen to the right eye when light is shown through the left eye? The answer is nothing, because neither pupil received the stimulus to constrict. If we extended the question a bit further, we could ask what would happen to the left eye if light was shown through the right eye. In this case, the afferent signal and the efferent signal would be fully intact. So the right optic nerve would be able to get the signal to the midbrain and to the pretectal nucleus on the right side. And if the efferent signals are intact, that means the pretectal nuclei will be able to send the signal to the Enger-Westphal nucleus on both sides and stimulate the ocular motor nerve. And then the ciliary ganglion will be stimulated, and then both pupillary sphincter muscles will be stimulated, causing constriction of the pupils in both eyes. So what we've decided is that if you shine light into the right eye, both eyes will constrict. But if you shine light into the left eye, the eye with the retinal detachment, neither eye will constrict. A name for this syndrome is Marcus-Gunn pupil, or an afferent pupillary defect, APD. This simply means that the afferent limb of the pupillary light reflex is dysfunctional, causing neither pupil to constrict when light is shown through the eye with a defect. Let's do another question. Let's say a patient is unconscious following a car crash. The medic on site shines light in both eyes without any constriction of either pupil. If brain damage caused the failed pupillary light reflex, what structure would be implicated. Okay, so basically a medical worker sees an unconscious patient and sees that the pupillary light reflex is not working in either eye. Now this is a test used to determine if the brainstem is functional in an unconscious patient. If we look at the pathway of the light reflex, we can see that the portion of the brain responsible for the reflex is the midbrain. So if there is damage to the midbrain, you won't ever get a signal to the pupillary sphincter muscles in either eye. So going back to the question, if brain damage caused the failed pupillary light reflex, the structure responsible would be the midbrain. So now let's talk about the horizontal gaze pathway for the eyes. So the signal starts in the right frontal eye field. We're just using right as an example now, but obviously this would apply for the left frontal eye field as well. So from the right frontal eye field, it will decussate to the left perimedian pontine reticular formation, or the PPRF, located in the pons. And then from there, it'll go to the left abducens nucleus, or cranial nerve 6, which is also in the pons. And from there, it'll go to the right medial longitudinal fasciculus, or the MLF. So it has now decussated back to the other side, and it'll innervate the right medial rectus subnucleus, cranial nerve 3, within the midbrain. So the net effect is that the left lateral rectus muscle and the right medial rectus muscle were stimulated at the same time, causing both eyes to look left. So if we were to insert the word left right here, and we started with the left frontal eye fields, we'd just reverse every one of these terms, and the eyes would finally actually look right. So let's draw this out to make it simpler. So here's figure 8.45 from your text, showing the horizontal gaze pathway. So as mentioned in the previous slide, if the patient wants to look to the right, the signal will start in the left frontal eye field and travel to the perimedian pontine reticular formation on the right. And then it will stimulate the right abducens nerve, and then it will also stimulate the left medial longitudinal fasciculus. So the net effect is that the left ocular motor nucleus, as well as the medial rectus muscle, will be stimulated at the exact same time as the cranial nerve 3 and the lateral rectus muscle are stimulated. So the patient will look to the right. Now this is a super high yield concept. So if you damage this left medial longitudinal fasciculus, then when a patient looks to the right, the left eye will stay focused in the center, and then the right eye will deviate to the right. Because the medial longitudinal fasciculus was never stimulated on the left side, so the left ocular motor nucleus could never be stimulated, so the left medial rectus muscle could never be stimulated. So when a patient has one eye looking to the right and one eye continuing to look straight, they will complain of double vision. However, the medial rectus muscle is actually fully functional. For example, if you ask a patient to look at your finger as you bring your finger closer to their nose and finally touching it, both eyes will converge, which means the medial rectus muscle on both eyes were stimulated, causing both eyes to look inward. This is called convergence. And this is possible because the medial rectus muscles in both eyes still work. What wasn't functional in this patient was the medial longitudinal fasciculus, which means that having both eyes move in the same direction, for example, to the right, is not possible because the medial longitudinal fasciculus is not carrying the signal. This is a concept to know backwards and forwards, so get familiar with this diagram. Let's do some questions to apply this. So let's say the left medial longitudinal fasciculus is damaged. What will happen to the patient when they look to the left? So when we look at this diagram, we know that if the left medial longitudinal fasciculus, going from here to here, if that's broken, then the cranial nerve 3 will never be stimulated, meaning that the medial rectus muscle on the left side will not be stimulated. So as we mentioned in the previous slide, when the patient looks to the right, they will get double vision. This means that this patient has a left INO, or left internuclear ophthalmoplegia. Also, the right eye will be overstimulated in an attempt to correct this left INO. So the right eye will demonstrate nystagmus, or repetitive uncontrolled movements. However, when the patient is trying to look to the left, which means the right frontal eye field will be stimulated, decussate to stimulate the perimedian pontine reticular formation in the left side, which will then stimulate the abducens nucleus. It will also go to stimulate the right-sided medial longitudinal fasciculus, which will stimulate the right cranial nerve 3, which will stimulate the right medial rectus muscle. So the patient can look left just as normal, because we did not need the left medial longitudinal fasciculus in order to look left. So going back to our question, when the patient looks left, what will happen? Nothing abnormal. Let's do another question. So let's say a patient demonstrates right-sided internuclear ophthalmoplegia. When will she likely experience double vision? So if you hear the term right-sided INO, you should immediately think of the right medial longitudinal fasciculus. So when a patient is trying to look to the left, the medial rectus muscle of her right eye will not adduct as it should, resulting in the right eye remaining straight and the left eye abducting. So both eyes will be looking at different locations, resulting in double vision. So in answer to our question, with the right medial longitudinal fasciculus being damaged, when the patient tries to look left, they will get double vision. So now let's extend the question. So a patient demonstrates right-sided INO and experiences double vision when looking left. So convergence is intact. Now where in the brain is the lesion? So we have determined that the patient has right-sided INO, so we are thinking of the right medial longitudinal fasciculus and that it is damaged. So she gets double vision when she's looking to the opposite side or the left side. So in this scenario, what we want to do now is identify where in the brain the lesion is. So we have here a picture of the midbrain and the pons. In which one is the medial longitudinal fasciculus? We'll recall that it is in the same part of the brainstem as cranial nerve 6, so in the pons. So we have the abducens nucleus pointing to cranial nerve 6, and we have that on both sides. So now focusing on the pons, we know that the medial longitudinal fasciculus should be very close to the abducens nucleus. And the medial longitudinal fasciculus is located very medially in the most medial portion. So if we draw a line down the center, it would be the most medial portion and close to the fourth ventricle. So we're actually suspecting these two right here. As you recall from the cranial nerve lecture, all of the motor nuclei are located close to the center, medial to the sulcus limitans. And all these sensory nuclei are located more laterally. So we have identified where in the brain the medial longitudinal fasciculus would be. We're thinking it's these two, and it is in fact labeled here. But what medial longitudinal fasciculus would it be? Would it be the one on the right or the one on the left? Well, as we've determined, if you have right-sided INO, then you have damage to the right medial longitudinal fasciculus. So we're thinking the one on the right. So of course, the medial longitudinal fasciculus travels to the midbrain, to the cranial nerve, but there's really not an identifiable pathway that's easy to identify, especially on a test in the midbrain. So that's why we're not really trying to identify the tract of the medial longitudinal fasciculus within the midbrain, so we've really just identified it easily in the pons. So now to review, internuclear ophthalmoplegia. So if you have a right internuclear ophthalmoplegia, then you have right medial longitudinal fasciculus damage. So you get double vision when looking to the opposite side, so looking left. And then you will get nystagmus of the left eye. So recall that nystagmus is repetitive, uncontrolled movements of the eye. So if you have nystagmus of the left eye, that just means that cranial nerve 6, which is fully intact on the left side, is overstimulated. So this patient is getting double vision when looking to the left, so the left cranial nerve 6 will be overstimulated and the lateral rectus muscle will be overstimulated, leading to repetitive uncontrolled movements when looking to the left to try to correct that double vision. Conversely, with left INO, that means that there's left medial longitudinal fasciculus damage, so they'll get double vision when looking to the opposite side, so when looking to the right, which means you'll get nystagmus of the right eye, because the right cranial nerve 6 is overstimulated. And recall that the medial longitudinal fasciculus and cranial nerve 6 are located in the medial part of the pons. Then cranial nerve 6 is located in the medial midbrain. So now let's talk about the sympathetic innervation of the eye. So sympathetic innervation starts in the hypothalamus, and then it goes through the lateral tegmentum of the brainstem, and then it synapses the lateral horn gray matter of C8 through T2, and it exits at T1. And then from there it enters the sympathetic chain. And then it synapses on the superior cervical ganglion at C2. Then it goes through the long ciliary nerve to the pupillary dilator muscle, which causes dilation of the pupil, so mydriasis. Now the superior cervical ganglion actually also sends innervation to the superior tarsal muscle, which causes lid retraction. Now the superior cervical ganglion also sends fibers to the sweat glands to cause sweating and the blood vessels of the face to cause constriction. So here's figure 8.44 showing the sympathetic innervation of the eye. As you can see, the signal starts in the hypothalamus, then it travels down the hypothalamo-spinal tract, and it uses the lateral tegmentum in the brainstem. Now it's very important that you recognize that this tract uses the lateral tegmentum in the brainstem in order to get to the spinal cord down here. And the reason this is important is because you can then determine why strokes will disrupt this pathway, because there's vascular supply to the lateral tegmentum. If you damage that, you're damaging the oculosympathetic pathway. The vasculature and strokes are discussed later in this chapter. So once the first neuron gets to the ciliospinal center of Budge, here we just have written the ciliospinal center and the lateral horn of the gray matter, which is C8 to T1, then through T1, spinal cord T1, which is this right here. This second neuron will exit the sympathetic trunk, and it's also called the preganglionic fiber. And it will travel up through the sympathetic trunk until it reaches the superior cervical ganglion, and from there it will synapse, and a nerve will leave the ganglion to innervate the pupillary dilator muscle, which causes mydriasis. So disruption of this sympathetic innervation will cause meiosis, or constriction of the pupil. The superior cervical ganglion also sends fibers to the superior tarsal muscle, which causes lid retraction. So with damage to the sympathetic innervation to this muscle, a patient will demonstrate ptosis, or drooping of the eyelid. It's also important to know that the superior cervical ganglion innervates the blood vessels of the face, causing constriction of the blood vessels. So denervation to this pathway would cause dilation of the blood vessels of the face, causing flushing. The superior cervical ganglion also innervates the sweat glands of the face. So if you damage that, then you're not going to have sweating. So as you can see, if you do any damage to the subclavian artery, or you get a Pancoast tumor, or you damage the jugular region or carotid region of the neck, then you could get Horner syndrome, leading to anhidrosis, flushing of the face, meiosis, and ptosis. So let's talk a little bit more about Horner syndrome. So if you have loss of the long ciliary nerve innervation, you're no longer going to get mydriasis, or activation of the pupillary dilator muscle, so you're going to get meiosis. If you lose innervation to the superior tarsal muscle, then you're no longer going to have lid retraction, so you're going to get ptosis. And if you lose sweat gland innervation, you're no longer going to be able to sweat with the face and forehead, so you're going to get anhidrosis. And if you lose vasoconstriction of the face, then you're going to get vasodilation, and the patient's going to be flushed. So some people like to remember Horner syndrome by just saying meiosis, ptosis, and anhidrosis. You can also think of vasodilation because of the flushing. So let's do a question. Let's say a patient develops right-sided ptosis and meiosis. This is on the right side. And this is secondary to Brown-Séquard syndrome. What was damaged, the postganglionic or the preganglionic sympathetic fibers? So this patient has Horner syndrome because they have ptosis and meiosis. So right-sided Horner syndrome. So is it the postganglionic or the preganglionic fibers that are the culprit? So if we look at this figure once again, recall that the preganglionic fiber cell body is in the lateral horn of the gray matter in the spinal cord, and it then enters the sympathetic chain until it reaches the superior cervical ganglion. So this is the preganglionic. Within the superior cervical ganglion are the cell bodies for the postganglionic fibers, which then leave to the tissues that they innervate. These are all postganglionic fibers. So in Brown-Séquard syndrome, which fiber would be damaged, the pre or the postganglionic fiber? We'll recall from section 2 of this chapter that Brown-Séquard syndrome is a spinal cord defect resulting in damage to an entire half of the spinal cord at a specific level. So it's a complete hemisection. So once you see it in those terms, you can clearly see the postganglionic fibers are not even touched by the Brown-Séquard syndrome. Rather, the preganglionic cell body is damaged. If the question stem indicated that a surgery was being performed on the neck near the jugular vein or the carotid artery or carotid sheath, so anything in this region, and then the patient developed Horner syndrome, we would actually suspect the postganglionic fibers. And that's actually really high yield to know. So if there's anything going on in the patient's neck, any surgery, any procedures, or anything, and the patient develops Horner syndrome, always think of postganglionic fiber damage. So now let's talk about the vertical gaze pathway. So it starts in the superior colliculus, which is responsible for ensuring that both eyes move up and down together, so conjugate gaze. The superior colliculus is located on the dorsal midbrain, and it can be damaged by a pineal gland tumor. So let's demonstrate this visually. So here on the left, we have figure 8.16, and on the right, we have figure 8.3, both of which were discussed previously in this chapter. So looking at figure 8.16, if we're looking at the dorsal or posterior aspect of the midbrain, we can identify the superior colliculi. So if we're looking at figure 8.3, we can see the superior colliculus right here is just inferior to the pineal gland. So it would stand to reason that in the case of a pineal gland tumor, the superior colliculus could easily be compressed, resulting in damage to the vertical gaze pathway, causing vertical gaze palsy. So now let's just briefly talk about the ocular muscles. So the medial rectus muscle will adduct the eye, and the lateral rectus muscle will do just the opposite. It'll abduct the eye. And the superior rectus muscle will elevate the eye, and the inferior rectus muscle will depress the eye. And that's all pretty straightforward. Now when we start talking about the oblique muscles, starting with the superior oblique muscle, this will actually abduct the eye, and then it will depress the eye, bring it lower, and it will internally rotate the eye, which is also called intorsion. So if we have both eyes right here, the superior oblique, which comes in, when it's stimulated, it will cause the eye to move in, intorsion. So the inferior oblique, similar to the superior oblique, will abduct the eye, but it's opposite in that it will elevate the eye and externally rotate the eye, or extorsion. So when the inferior oblique comes, this is where it's located, and when it's stimulated, it'll cause the eye to move out that way, so extorsion. So this is just a brief overview of the ocular muscles. It's pretty straightforward, and you just think that if you damage the medial rectus muscle, you won't be able to adduct as much. So if we're looking at the eyes, if you damage the medial rectus muscle of the right eye, you're not going to be able to look medially with the right eye. And then if you damage the lateral rectus muscle of the right eye, you're not going to be able to look laterally. Then the same principle is true for the superior and inferior rectus muscles. And if you damage the superior oblique muscle, this right here, then the eye would not be able to abduct, look this way, depress, look this way, or internally rotate. So essentially, the eye would look up in this direction. And this situation is discussed in great detail in the cranial nerves lecture of this chapter. So the innervation, which is discussed in great detail in the cranial nerves lecture of this chapter, can also be remembered via this little mnemonic. So it's almost like a chemical formula. So the lateral rectus muscle is innervated by cranial nerve 6. The superior oblique muscle is innervated by cranial nerve 4, and all the rest are innervated by the ocular motor nerve, cranial nerve 3. So LR6, SO4, R3 is just a quick way to remember it. But some quick things to remember is that if you damage the lateral rectus muscle, the lesion will lead to medial deviation of the eye. And if you damage the superior oblique muscle, the lesion will lead to medial upward deviation, which we discussed on the previous slide. And the rest, cranial nerve 3, if you lesion that, then you'll get a lateral downward deviation plus mydriasis. So if, let's say, we damage the right side, right here on the right, then we'd get mydriasis, blown pupil, if you will, and then you would get a lateral downward deviation. The eye would look down that way. And that concludes this section.